Welcome to today's webinar presented by SAMHSA's Gain Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's webinar is part 2 of our webinar series on competence to stand trial and is titled COVID-19 in the San Luis Obispo County, California criminal justice system, the balance between managing mental health and contagious disease among people with serious mental illness in jail. The presenters today are Teresa Pemberton and Dr. Christy Mulcairn, and I will introduce them shortly. I am Ashley Kreider, and I'm a Senior Project Associate with Policy Research Associates. Before we start our presentations, I have some housekeeping items to review. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or regarding the technology, please type them into the Q&A pod on the right of your screen. We will address as many of your questions as the presenter as time permits. We will also be conducting a poll in a few moments and appreciate your participation. When you see the poll pop up on your screen, please enter your responses. The webinar is being recorded and slides will be disseminated via the Gains listserv following the webinar. We will also notify you when the webinar recording is posted to SAMHSA's YouTube channel. A certificate of attendance will be available for download at the end of the webinar. Please note the certificate is for personal portfolio use only and is not for CEU credits. There is ASL interpretation for this event. To view ASL interpretation, go to Layout in the upper right-hand corner of the screen, then select Hide Non-Video Participants, and then change the layout view to full screen. Finally, select View All. This icon looks like opposing edges of a rectangle. The interpreters for today are Jason Farr and David Gritzer. There is also live captioning for this event. To view live captioning, select the Accept button in the Multimedia pod located in the lower right-hand corner of your WebEx screen. The color contrast of the live caption pod can be changed as needed, and the high contrast style is recommended for best visibility. Next, I would like to introduce today's webinar agenda. First, Roxanne Castaneda, a public health advisor at the Substance Abuse and Mental Health Services Administration, will provide some comments from SAMHSA, followed by today's presentation. Now, I'd like to turn this over to Roxanne Castaneda for opening remarks.
Thank you, Ashley. Hello and welcome. I'm Roxanne Castaneda, and I'm the Center for Mental Health Services Criminal Justice Lead to the SAMHSA Gains contract and the SAMHSA Early Diversion project. Before I begin, I would like to thank Dr. Lisa Callahan and Sam Rogers for their endless excellent work on these community of practice competency to stand trial projects, and Ashley Kreider for her assistance today. In SAMHSA's publication, 8 Guiding Principles for Behavioral Health and Criminal Justice, it discusses arrest and incarceration as often destabilizing in an individual's life, including their housing, healthcare, employment, and social connectedness. Researchers have found that even brief incarceration leads to adverse consequences, including loss of employment and future employment opportunities for physical and behavioral health due to breaks in healthcare services and treatment, loss of housing and future housing opportunities, and disruptions in family life and social connections. Once in the criminal justice system, individuals with mental and substance use disorders stay in jail longer, have an increased risk for self-harm, and receive more frequent punitive responses to infractions. Due to funding and staffing limitations, many people with mental illnesses do not receive the services they need, and their conditions often worsen inside jail settings. For individuals already receiving medications and treatment in the community, these services may be interrupted during incarceration, creating lapses in treatment and difficulties in resuming treatment upon release and reentry to the community. Without continuous coordinated care throughout and following incarceration, these individuals are at risk for reincarceration, emergency department use, and hospitalization. In addition to this, the pandemic of COVID-19 stopped our way of life as we know it. Severe illness and death, quarantine, limited face-to-face contact during treatment, lack of access to vaccination, telehealth and its challenges with technology, loss of jobs, permeates our daily lives. Today, we welcome experts from San Luis Obispo, California, who will share their experience with COVID-19 and the CJ system. Ashley?
Thank you, Roxanne. And now I'd like to introduce our speakers for today's presentation. Teresa Pemberton has 17 years experience working in the substance abuse and mental health field with adults, youth, perinatal, co-occurring, and forensic populations. She has supervised multiple treatment courts which provide a team approach. She has managed a variety of grants that have encouraged and grow innovative services in the community. She is currently the division manager of the Justice Services Division for San Luis Obispo Behavioral Health. Dr. Christy Mulcairn is the first Chief Medical Officer for San Luis Obispo County Sheriff's Office, hired by Sheriff Parkinson in March 2018. She oversees the delivery of inmate health care in the San Luis Obispo County Jail. She has led the jail's efforts in COVID response, medication-assisted treatment, the Stepping Up Initiative, and reentry planning. Dr. Mulcairn's career in San Luis Obispo County started in 2016 as a Deputy Health Officer for the Public Health Department. Prior to moving to San Luis Obispo, Dr. Mulcairn worked as a pediatrician in San Francisco, Santa Clara, and Orange counties. Before I turn things over to our presenters, there are some observations about who is participating in today's webinar. Many of you attending today are from urban areas, followed by a split between rural and suburban pretty evenly. The majority of professional affiliations are probation, parole, government, community-based, corrections, and judiciary. Thank you so much for joining us for today's presentations. And now I will give it over to our presenters to begin the presentation.
Thank you for that introduction, and thank you so much to the Gaines Center for having us today. I'm Christy Mulcairn, Chief Medical Officer for the San Luis Obispo County Sheriff's Office, and I'm going to start our presentation and then hand it over to Teresa for the end. Today's objectives are to talk about the unintended mental health consequences of quarantine and isolation that were implemented in our jail in response to the COVID-19 pandemic. We're also going to talk about how decarceration efforts decreased our jail population, yet did not, but yet left behind a very vulnerable part of our population, which are the patients with serious mental illness. We're going to understand that following data in real time can show trends that and can promote buy-in from county leaders, especially around the Stepping Up Initiative. And then Teresa's going to talk about our county's mental health diversion program and how it adjusted to the challenges of the pandemic to enroll people into the program to divert them out of jail. This is our outline for today. I'm going to introduce you to our county, talk about some of our baseline data, go over COVID-19 and the changes we implemented, and then what we saw in the data in a response to the pandemic. We're going to talk about decarceration, what that meant in California, discuss mental health diversion program, and then leave time for questions at the end. This is beautiful San Luis Obispo County. We are located on the central coast of California. We're a tourist destination, a college town, and it has been said that we're one of the happiest cities in America. This is our board of supervisors who govern our county. However, we have a very vulnerable group of people in our jail system for whom this is not true. So our around 500 people to 550 people pre-pandemic who are in our jail have a high rate of chronic diseases including mental illness, substance use disorders, and over 50% of the people in our facility report being homeless. I really like data, so I'm going to show you guys a couple of slides from our homeless census and survey that was done in 2019. So this group asked people who are suffering from homelessness what their health conditions were. And so this is what the people who are homeless in our county reported. And I want to point out that 31% of people reported having mental health conditions. And homelessness is not just a San Luis Obispo County problem. As you can see, our state and the entire West Coast have the highest rates of homelessness throughout the county, with New York, Alaska, and Hawaii joining us. These are our local rates of homelessness, and the number 1,483 actually puts us higher than the state average for homelessness in our county. And as you can also see, almost 80% of the people who are homeless in our county are unsheltered, meaning that they're not living in a homeless shelter. They're living in an encampment or in the riverbed. This slide's a little confusing, so I'm going to take a minute to tell you what it means. When people enter our jail, we ask them where they live. And I wanted to know how many people entering our jail reported being homeless or transiently housed. So we looked at the people who were booked throughout 2019 and 2020. We counted each person once. And if the person had ever reported that during the year that they were homeless or transiently housed, we counted them as homeless or transiently housed. And so as you can see, 58% of people in 2019 and 63% of people that entered our jail are homeless. And validating this number is some data that was collected by our local syringe exchange program. They come into the jail and treat opioid overdose prevention and naloxone administration to our jail patients. And they collect anonymous data that they take that's never seen by the jail health team or the custody team. And so these patients that participated in this training also reported about a 50% rate of homelessness when they worked with the syringe exchange. So now that you know that our jail is filled with people with chronic diseases and homelessness, and that people with homelessness tend to have more problems in general, I'm going to talk a little bit about mental health. So this slide is from NAMI. This is shows that 1 in 5 people, so about 20% of the population in the United States has mental illness, and this is pre-pandemic. And about 5% of people in the United States suffer from serious mental illness. And unfortunately, this number is more than doubled in corrections. So 2 in 5 people in corrections, 40% of people on average have a mental illness. Suicide is the leading cause of death in jails. And then less than half of people with mental illness who enter a jail receive mental health treatment while they're in the jail. I want to emphasize that this is not meant to be a criticism of jails and healthcare that's provided. It's more trying to show you the burden of disease that these people have when they enter the facility and how difficult it is to make sure that their needs are addressed. A quick note about the race and ethnicity data in our county. This is from our census from 2 years ago, and we should have new data coming soon. And I want to show you that people of color are disproportionately represented in our jail, even though the numbers are relatively small. So this pie chart shows you the number of people, or the percentage of people entering our jail by bookings who fall into the race and ethnicity categories. And then on the lower left, you can see the census data from the previous slide. So in introducing you to our county, I want to make sure that I go back over the past couple of years, because it's hard to talk about where we are today without talking about how we got here. In early 2017, unfortunately, we had a very highly publicized and tragic death of a seriously mentally ill inmate who was in our custody. He was undergoing an acute mental health crisis at the time. And this death really rocked our community. It caused our board of supervisors to look at what was going on in the jail and dedicate resources to make sure that something like this didn't happen again. As a result, Chief Medical Officer position, that's my position, was created, and I was the first person to have that position. Our county also adopted the Stepping Up initiative, which I'll speak about in a moment, and we were awarded a grant to track data for our Stepping Up initiative. Assembly Bill 1810, which is also known as mental health diversion, was passed, and Teresa's going to speak about that. We started a mental health diversion program. We outsourced our jail healthcare to a private company. We added Teresa's position, and then COVID-19 hit. A quick review on the Stepping Up initiative. This is a national initiative which jails can join, counties can join, and the goal is to reduce the number of people in jails with mental illness. And there are 4 ways that this can be done, which are outlined here. And the thing about the Stepping Up initiative is it's very data driven. So counties are challenged to collect baseline data, and then as changes are implemented, to track the numbers to see if the changes are making a difference. For us, one of the first steps in our journey with the Stepping Up initiative was to implement universal mental health screening at booking in our jail. And there are many options for screenings. We chose the Brief Jail Mental Health Screen, and it's an 8-question screen that the nurses do at intake. And the person either screens positive or negative, and if they screen positive, then they are referred to mental health staff for a further assessment. And here is the data since the beginning of when we implemented our screen in the very beginning of 2018. So the blue lines show the number of people who screen positive on this screen at intake. And the green line shows the percentage of people who are screening positive. In 2020, our jail population was significantly reduced because of many efforts to decarcerate, which I'll talk about. But as you can see, the green line really hasn't budged. So over 3 years, as we have implemented many interventions, crisis training for our patrol and correctional deputies, a CAT team that intervenes in the field, mental health diversion, our number of people coming into our jail that screen positive for mental illness has not changed. Something else that we follow is one of the questions on the screen is whether or not the patient has been prescribed mental health medications in the community. So it's another measure that we use to try to see how many people we have in our facility who have mental health needs. And again, as you can see, the green bars show that although the number of people have decreased because our population and our bookings decreased during the pandemic, the blue line shows that the percentage of people reporting being on mental health medications has not changed and is usually between 15 and 20%. Interestingly, even though only 15 to 20% of people entering the jail say that they are either on or should be taking mental health medications, people who stay in the jail, over half of them end up on mental health medication. So clearly, more people have a need to be on mental health medications than are being prescribed in the community, or maybe they're not reporting it when they come in. So in order to track people with serious mental illness, the Stepping Up initiative challenges counties again to define serious mental illness and to come up with a shared definition so that everybody is talking about the same population. And this is our definition. It is from the DSM-5. We didn't make it up yet. It did take our county some time to agree upon this definition. So we were doing pretty well. It was the beginning of 2020. We were marching along with the Stepping Up initiative. We had real-time data collection through our Stepping Up grant. This is a part of a dashboard that we had developed to track the number of people with serious mental illness and track their length of stay. We felt pretty good about where we were. Our mental health diversion program had started. And then COVID hit. So for those of you who work in healthcare and corrections, you know how difficult infectious diseases are to contain in congregate settings. We had had a flu outbreak earlier in 2020, and despite all of our efforts, it had spread throughout a lot of the jail. And so when we heard about COVID and we were starting preparations, we were pretty nervous. And I want to use this opportunity to just speak about the amazing team we have over here in the jail. Really, none of the changes we implemented in response to COVID would have been possible without an amazing custody leadership team, and really they were the ones that made us as successful as we were able to be. Lompoc Prison, I have on this slide, is 60 miles down the road from us. They're a federal prison, and they had one of the worst outbreaks nationwide very early in the pandemic. And to say it made us nervous would be an understatement. So early on in the pandemic, correctional facilities didn't have any guidance from the Centers for Disease Control on how to handle the pandemic and what to do with our patients and how to screen staff. And so we were really piecing it together. And then in May, they came out with a guiding document. And in the document, we were instructed to create a quarantine unit for all fresh arrests, to keep them in a unit for 14 days in order to contain anyone who was bringing COVID in from the community. So we dutifully, created a quarantine unit. Our classification team is amazing. They cleared out 2 housing units, and we had a place for people to go for the first 14 days of their incarceration. And pretty quickly, we started to see that the people in the quarantine unit were doing really poorly. They were distressed. They were having acute mental health crises. And we assumed that was because they were having less interaction with other people, because they were supposed to be quarantined so that they didn't unknowingly spread COVID to somebody else. So here we had done a really good job. We were months into the pandemic without an outbreak. We were so proud of how we were managing the pandemic, yet our patients were really suffering. And so we had to change our approach immediately. We increased socialization while people were in quarantine. So we brought them out of their cell in small groups, taking a risk that they would pass COVID to each other, but yet realizing that the social interaction was more important than the infectious disease containment. We increased access to mental health staff. We gave more phone time. We actually had phone time donated by a local community-based organization. We offered more activities, and this really made a huge difference. Yet, as community rates rose, and with this change in our procedure, we did have our first and only major outbreak of COVID-19 in our jail. 63 inmates and 7 staff ended up infected. And despite all of our efforts to isolate and separate people, COVID proved impossible to contain. It got into one of our dorms, and 95% of the people in that dorm ended up infected. So with the knowledge that COVID-19 spreads very easily in correctional settings, there was both a local and a state effort to reduce the number of people in the facilities. The thought being, if you can, have people distanced from each other, there's a chance that there will be less spread in the correctional setting. So locally, what we did is we stopped accepting people that had committed probation violations. We weren't accepting court commitments. Our sheriff said, reached out to local police departments and said, please don't bring people in unless it's absolutely necessary. And it worked. Our population started to drop, and then zero bail was passed in California. So zero bail, and I'm not a lawyer, so I'm not going to get into the technicalities of what was passed, but in general, it took crimes that previously had cash bail associated with them, and it reduced that bail to zero. And these were non-violent crimes. So overnight, we found that not only were most people that were being arrested not staying very long, they were being cited out almost immediately, but we also saw that between 50 and 100 people that were currently in custody were going to be released in the next few days. So as I've told you guys, over 50% of our jail population suffer from homelessness and chronic diseases. And during the pandemic, a lot of shelters weren't accepting, homeless shelters weren't accepting new patients because they were either full or they were experiencing outbreaks themselves. Many community services were either running at very low capacity or were closed. Clinics were closed. And so we were trying to discharge plan and do reentry planning for people and they really had nowhere to go. And this really caused our team to start looking at the reentry planning process and how we can do it better. And that effort remains today. This shows you how decarceration affected our jail numbers. If you look at between March and April of 2020, zero bail was passed in April of 2020. Our number immediately dropped by almost 120 people and then continued to be low and has now creeped up a little bit. Like I said, we're usually around 430 to 450 right now. We're continuing to track people with serious mental illness in our jail during this time. And what we would have expected was, as our jail population dropped, the number of people with serious mental illness would drop. Yet in late summer, we noticed that not only were the number of people with serious mental illness not dropping, but they were actually increasing. And we were shocked. We could not believe that not only were the people here not decreasing in number, but they were actually increasing. And so our team got together and we sounded the alarm. We made sure that all of our leaders knew that this was happening. We talked to the courts, we talked to the sheriff, we talked to the Stepping Up executive team, who's comprised of county leaders. And we said, this is happening. We have data to prove it. And we all tried to figure out what to do next. The first thing that we started to ask is, who are these people that we have? Why are they still here, or why are there more of them? Is this only a problem with our jail, or is this reflecting something that's going on in the community at large, or the state, or even the country? We knew that acute mental health crises were up in our county, and we wanted to know, are other jails also having the same problem? And then more importantly, what can be done about it? So looking at what was happening nationwide during the pandemic, the CDC reported that the number of people with mental health symptoms had doubled during the pandemic. So if you remember from the beginning of my talk, 20% of people in the United States have mental health issues, and now 40% of people in the United States have had mental health issues. We also knew, as I said, that in SLO County, mental health symptoms had increased, overdoses had increased, And we also knew in speaking with other jails, anecdotally, they said, yeah, we're seeing the same thing. So we looked at the data, we looked at the people that we had in our jail, and we said, what are their charges? Are they sentenced? Are they still going through the criminal justice process? Where were they arrested? Is there one arresting agency who's bringing in more people than others? How long have they been here? And we started to try to see if we could find any trends. And then we also compared our numbers to other jails in California. And comparing rates of serious mental illness across jails is not something that we're really able to do yet, because every jail has a different definition of serious mental illness and a different way that they track it. So the best way we have to compare apples to apples across jails is through, it's called the BSCC. It's the state body that regulates jails and makes sure we're complying with the law, and also requires us to submit data every month. So I pulled the data that I was able to try to compare us to other jails our size and other jails who are geographically close by us. And I like this graph because it shows you that when you're looking for a trend, you don't always find it. Our line is the red line, and we have, as you can see, a much higher rate of people on mental health medications than the other systems. Yet there's really no other market increase in any of the other jails that we looked at. So even though anecdotally other jails were saying, yes, we're seeing the same thing, the numbers didn't really show that. So in sum, what we found after all of this research is that we had about 20 people who were waiting to go to state prison and had been waiting for some time, and those people had serious mental illness. And the reason they were waiting is because the state prison system was struggling with many outbreaks of their own. And so they had stopped accepting transfers from our county. We also had a state hospital wait list, and state hospital had shut down to admissions for the same reason. We had challenges getting people with serious mental illness through court because we had implemented a video court system that was slower than in-person court. And then, as Teresa will talk about, our diversion program had really stopped accepting new patients during the pandemic, not because the program had stopped, but because of the inability to come into the jail to find suitable clients. And so after looking at this data, we started to say, what can we do? I mean, we're still in the pandemic. There's sort of no end in sight. And so what can we do currently and urgently to try to get these numbers down? Where in this process of arrest, booking, going through the criminal justice system, sentencing, going to prison, where can we intervene? And that is where Teresa's team comes in. Oh, Teresa, you're on mute.
There we go. Thank you, Christy. So at the same time as that data was starting to point in the direction of where people were stuck in custody, we were starting our diversion program. We developed a stakeholders group. We were trying to get grants. We had 2 grants lined up and ready to go. And the new California diversion law was in effect, and counties were trying to figure out how to make that work. It was giving us the opportunity to address people before they go to trial, before they get sentenced. And the goal was to get them out of jail sooner so that they weren't decompensating, so that they were in treatment and not coming back over and over again. So as we came into COVID, we were noticing all these challenges really just came to light. The slow court process was an issue. When COVID hit, courts basically shut down for a bit and then moved very slow as they tried to adapt to a Zoom version of court. And we saw referrals coming to almost a screeching halt. We also were noticing that people that were incompetent to stand trial were staying in jail longer. state hospitals were stopping their intakes. So no one was able to go, meaning they had to stay in custody waiting. And even our internal JBCT, jail-based restoration, was still working, but it still took a lot of time. The other challenge we were finding is that the attorneys were referring everyone they could think of. They just threw everything our way. And a lot of the referrals were very inappropriate. We had people with substance use disorders that really was substance-induced psychosis, really not what we were trying to treat. They were sending very violent crimes our way. And they were frustrated that we weren't taking anybody. And we were frustrated because we were wondering where are all those people that are in jail that we want to bring into treatment. And then the other piece was we weren't able to track any of the clients that already had been referred. They were stuck in jail. And we were seeing that they may be stable now on medications, but we didn't know that. We had to wait for their next court hearing, which could be 90 days down the road at the pace that courts were going at. We didn't know if their restoration was completed. We didn't know how they were doing to get them out of jail quicker and help the jail reduce their population. So we had some challenges. So we knew we had to do some brainstorming. So with those challenges in mind, we had to find out what we wanted to do. We can't take steps forward if we don't have a plan. So the things that we decided to work on were improving the monitoring so that we knew when someone was ready, we could immediately get them back into court and into our program. We also knew we wanted to engage people earlier in the process, maybe even before they went to court the very first time. We had a grant previously that really showed the incredible strength of having personal relationships. That grant put court screeners directly in the courtroom. And what the data from that showed was that people who had that contact with a person during that time when they're very vulnerable and ready to look at solutions, those people came into treatment. The data was really clear. Prior, a judge would say, go to mental health and get screened, go to drug and alcohol, get screened, and people weren't going. But when we added the court screeners, people were showing up. So we wanted to keep that going. We wanted to expand that to this program. Of course, we wanted to increase our referrals. We have grants, we have data we've got to collect, but we also wanted to get people out of the jail. And then lastly, everyone was so frustrated with the incompetent to stand trial process because it was so slow. And with COVID, it was moving incredibly slow. Our first 3 diversion clients had an average of 455 days in jail. That stunned us. And we took a look at that, and they were people who were incompetent to stand trial, would go and be restored, then would come back, stop taking meds, and then go back to the hospital. So we knew that cycle was there, and we wanted to fix that. And we knew we wanted to work on those past successes. As I talked about, the court screener grant, that helped us a great deal. And we had grants around stepping up, and we had built really strong collaborations with other people in the community, other agencies. And we knew we could utilize that to make a difference. So we had to identify our goals. So we knew what we were going to ask for. And the first thing we needed to do is decide what behavioral health needed to do internally. How could we get into the jail? Who would we send? And what would that look like? We also knew we were going to need to coordinate with the jail. Prior to it being contracted out, we were the provider, so we knew a bit about how it worked. And we knew there were daily staffings. And we thought, if we attend those staffings, we're going to know how people are doing. The information is there. And we knew if we could get into the jail, we would be able to see people in person. So that was definitely a goal. And we wanted to conduct earlier mental health screenings so that we could have that information ready for the court, and they wouldn't have to then assign it, wait for another court date for our decision, and keep going. And we wanted to provide the attorneys with information about who is a good fit for this program. It's a win-win for both of us. They're frustrated, we're frustrated. we can already have information for them if we're in the jail. So we were ready to make it happen. And it's always the big question of, where do you start? How do we get into the jail? How do we move forward? And you have to have champions, and we had that. We have an excellent group of judges. Our mental health diversion judges are so motivated to get people into treatment, to stop the cycle of incarceration. And so we had them on board immediately. And then we had Dr. Mulcairn, and that relationship was in place through the Stepping Up initiative, through the stakeholders meetings. We already had that relationship, and I knew that we had that shared vision. And so it was a perfect setup. And we knew we both wanted to interrupt the 1368, the IST process. So we had the people in place. So how did we do it? Dr. Mulcairn was able to introduce us to the jail psych services supervisor. And from there, we set up a meeting with him. Behavioral health explained in that meeting what our vision was, what we wanted to do, and let them know how that would look. The jail psych services supervisor let us know the struggles in the jail and what they wanted. And they were both the same. And we knew we had a win-win opportunity ahead of us. So we had to work out some details. We had to figure out who on our team, who on their team. And we realized in our conversation, we needed to include custody. These are the people that are going to move us around the jail. These are the people that are going to be affected by us coming in. And we needed to remember, when you go in the jail, it's their house and you follow their rules. So we wanted to really honor that. They have structure. They have to have structure. They're working on safety. And so we wanted to cause the least amount of disruption for them. And so we identified the day that would work for both of us. We had to streamline the clearance process because in the middle of COVID, who's going to have another person in the jail? So we had to really look at that seriously about, is it worth having one more person enter the jail? And we had been already working with clients and using really good protocols and decided that the benefits were definitely going to outweigh the risks. So we streamlined that, got our staff certified to come in, and we identified the point person. It couldn't be the supervisor, he's super busy, but he gave us the person on the psych services side to identify with, to talk to. And we had a custody officer assigned to us, and it was the same person all the time, which was perfect. We also knew we had to attack that incompetent to stand trial dilemma. And our judges knew very clearly about that. They'd pushed back on state hospitals trying to get people in faster, but with COVID, that wasn't going to happen. And we were also getting a lot of education from the California Department of State Hospitals, who had one of the grants we had, and they did a lot of education. Part of that education consistently was touching on starting court-ordered medications in the jail sooner. And that's always been a touchy spot because people think of forced meds. And so the system was, you did not give meds until they went to the state hospital or until they entered the restoration in the jail. And that delayed the person getting help all along. It also leaves them ill while they're in jail, which is a very, very difficult thing. So we learned about how they would be willing to give us expert advice on starting those meds and how to do that in the jail. They also provided their legal experts. Their legal team had been part of the team that had written the law and knew it inside and out. So our judges, we had a meeting with the judges and Christy and myself, and they were able to show us how we could, we call it off-ramp people from that process and speed up the system. So the reality is that even if they're not restored and they come into treatment, that's fine, it's pre-plea. They haven't even gone to court yet. And that incompetent to stand trial still sits there and waits. If they graduate, that charge, that court case goes away. If they don't, the incompetent to stand trial is still sitting there, and they will continue with that process. So we had a way to move people faster into our program. And our judges began to take that information to the other judges and spread the word so that other courtrooms knew that we could do this process. So where are we now? We're doing great. We have staff going into the jail. Our med manager is a licensed psychiatric technician, which in California is a nurse who has very specific psychiatric training. She can give meds, she understands medical issues, and she understands psychiatric issues. So she was our perfect pick to go in. And what happens now, this isn't how we originally planned it, but what is happening now and is working great, is that she receives a list of names the night before she comes, the afternoon before she comes, and she can review those names in our electronic health record to see if they've been treated by our county in the past, to see if they respond to meds, see if they respond to treatment, just get a basic overview of the client. And these were people who maybe came into custody since her last visit. It might be people who have stabilized on meds. And it sometimes was people that custody officers had identified. So it was a great system. We were getting to see the people we needed to see. We also had staff that are reviewing the legal charges that people have that are coming into our program. And we have them review the basic legal eligibility. Was it a violent crime that would make them ineligible? Was it something that is unable to be in diversion? So we already knew that when we'd go in. And then with that information, we're able to help the jail with discharge options. They often have a struggle with discharge planning. And our psych tech knew all the ins and outs of what's available in the community and is able to help them identify things if it wasn't our diversion. We are meeting with people cell side, and that's working great. Developing that rapport, helping people know what's available, talking to them personally has really helped with people being willing to come in to the program and start medications. And so we are starting our court-ordered medications as soon as they're received. And a lot of that goes to the jail. As Dr. Mulcairn talked about, when we had the death in the jail, we all stepped back. Everybody had to take a look at it. And the jail did a fantastic job of looking at their mental health unit and identified other counties that were creating a mental health unit that utilizes positive reinforcement and incentives and all of those things to create good behavior. And it's very successful. That's the perfect environment to begin medications. And the supervisor for psych services had worked at Department of State hospitals and knew that's how they do it. When we send someone there, that's how they try to get people on meds. So it was a perfect setup. And we're having people start meds sooner, they're clearing sooner, and we're getting them back into court sooner. We're not waiting for that certification of competency. If they fit our program, we're bringing them in, and it's working. So success is breeding success. Word spreads. We're now getting kites from individuals, inmates in the jail that are hearing about the program. They're asking to be seen by the diversion med manager. We have custody staff now bringing names and saying, Jana, this is a great person. I really think this is what you're looking for. And so other custody officers are now hearing and bringing them. And they're also learning about the success of the program. So when we have graduations, we advertise it to all the partner agencies. And so word spreads that, did you see so-and-so? You remember how bad he was? And look at him now. He has housing, he's doing well, he's stable. And that makes people really excited, and word spreads some more. So In our first quarter of doing this, 21% of the referrals were coming from the jail, and now it's just growing and getting better, and that number will increase. So in summary, we know that mental health is a huge challenge in the US, and it's really disproportionate in our corrections system. The infection control that we're trying to use in the pandemic sometimes gives us unwanted side effects. And you get things fixed in one area, but it creates a problem in another. And so some easy interventions improve that through socialization and decreasing the time these mentally ill clients had to be alone. It was reducing their symptoms. And that the whole team had to work on that. It's not a one division fix all. And then decarceration was a great plan. It did reduce the number of people in our jails, but it did not work so well for our vulnerable population. The mentally ill continued to be high numbers and increasing in our jails. So we had to work. A lot of people were being released that had nowhere to go and were very quickly being rearrested and brought back in and not offered zero bail again. And then they weren't being able to get into the state hospitals because of COVID. So we knew we had a problem. The real-time data, that was huge. Dr. Mulcairn's collection of data gave us the ability to see where we were stuck and to see that we had a problem coming down the line. And it took all of the stakeholders to assist with this. It was the courts, it was behavioral health, it was the jail, the sheriff, it was our CAT teams. It was all of us working together to make this work. And we did that through a grant. Again, another grant. It's amazing what you can do. We had a staff member that was able to collect all that data. So even though diversion enrollment came to a slowdown during the pandemic, by working together with the jail and being creative and collaborating with them, we overcame those barriers. And now we have diversion staff entering the jail, which really bridges that gap and gets people into the program faster. And it took working with the experts and other counties to problem solve. We can't find the solutions all by ourselves. And some of our best solutions came from other counties, and we adapted it to fit how our county functions. And with diversion, we're seeing reduced recidivism. People aren't going to be coming back into the jail, and we're having better outcomes. So it was a win-win for all of us, and it's a great solution to the problem. Thank you so much for your time. Christy and I are privileged to be able to share with you today. Are there any questions?
Thank you both. We now do have some time to address questions from the audience. If you haven't done so already, please type your questions into the Q&A pod to the right of your screen, and we'll answer as many as time allows. So first, a quick one, I think for Dr. Mulcairn from the earlier presentation. Does your definition of homelessness include couch surfing?
Yes.
Easy answer. Yes, thank you. And then also, one of the earlier discussions around court process, were jury trials stopped? Did that add to the slowdown of the whole process?
Jury trials were only for a short time while they figured out how to bring Zoom into the picture and how to isolate the courtroom. So it was for a short time they were, but then they brought them back, but only in a couple of courtrooms.
Thank you. In the DSM diagnosis under the mental health diversion slide, does that include substance use disorder as a qualifier?
We did not at the time take that into consideration. We were looking at severely mentally ill.
Okay, thank you. And then a couple of questions around the restrictions going into the jail during COVID. I know that's opened up a little bit, but questions around how you monitored the process when you were prevented from going into the jail due to COVID.
Is the question monitoring the diversion process? Is that what you thinking?
I
Okay,
believe so.
go ahead, Teresa.
So initially, we just had to talk about what the same protocols the officers were doing. It just was adding another person. But as soon as we were able to be immunized, we utilized that as a additional protective factor. It was really just a matter of being willing to follow the jail's protocols. And so having temperatures taken, masks worn, sanitizing our hands, it really was a pretty good process. We were able to do it.
Thank you. I believe this is for Teresa. I mentioned that bail was replaced by a pretrial assessment. How would that pretrial assessment work?
So bail wasn't replaced with a pretrial assessment. What we did was anybody who had mental illness in the jail, we were screening to see if they would be eligible for diversion, if they met the criteria of the law, and then if they would benefit from our program, which is one of the criteria. So we utilize that as a way to identify people we could get out sooner.
Thank you. How would someone go about giving the information and statistics on this subject to a county jail? How would they approach that?
Can you repeat it? Sorry, I don't understand.
Sure. I think kind of where to go from here. So any advice around taking some of the promising practices that you did in SLO and giving it to a different county jail?
Oh, I see. Yeah, so I really want to emphasize that, you know, when I give this talk and it's 45 minutes of 4 years compressed, you know, it seems like it's just all progress and super, you know, easy and we made these great strides, yet it's very slow. And what I would say to start, at least where we started, is look at what data you have, what numbers do you have already. Don't try to reinvent the wheel. Look at what you already can collect and start to actually look at the data and show people what you collect. Hey, look, you know, I can look in the electronic medical record and pull the number of people at any one time who have mental illness. Or there's this one question that the officers ask at booking that would reflect, you know, mental illness, or whatever you have. Sort of take stock of that, and then do one thing at a time and celebrate the small successes. So for us, implementing the brief jail mental health screen was a huge deal. The nurses didn't want to do it. They wanted mental health staff to do it. Mental health staff was willing to do it, but they weren't already part of the intake process, and custody didn't want another person in the Sally Port. So it was a huge discussion. And so once we implemented that, we just sort of took a deep breath and said, okay, now we've implemented this screening. Let's give it a couple of months to see how it goes. So, and I'm also happy to talk to anyone, you know, I think our contact information is at the end, but being in healthcare in a correctional setting, I've definitely run up against a lot of barriers and have navigated those along with, and Teresa as well. So we're definitely happy to talk with you and help you in any way.
Thank you. I appreciate that. There's another question around contacting you both with more information. So I'm taking the liberty of putting your email addresses back on the screen here. A couple of other questions at this point. What funding source do you use for medication in the jail, and is the jail responsible for the cost?
Great question. I will try to keep it short because I do have a lot to say on this topic, but in California, all healthcare that's provided in the jail is county funded. So even if someone has Medicaid, the minute they come into the jail, that's suspended, and everything that is provided to the inmates is from our general fund. And that's hard. It's a hard place to be in because taking care of people with a lot of chronic diseases is really expensive. The one exception is if someone gets hospitalized, our state Medicaid program will kick in after 24 hours. So all medications are funded by us. But I do know that there is something that's being proposed at the federal level, which is a Medicaid expansion, where Medicaid would be available to people with the 30 days prior to release from custody. So they would have active, it's Medi-Cal for us, but active Medi-Cal 30 days prior to release, which would be huge because you could start expensive long-acting injectable medications. You could get people on medication-assisted treatment. And so everything would be covered in those 30 days.
Thank you. If someone is granted treatment over objection at a state hospital, can it be enforced once the person goes back to jail? And this person says in New York, court-ordered medication can't be enforced at DOC.
So once someone is restored, their court-ordered medication, their order is no longer valid. So the court-ordered, I think that's answering the question. So the court-ordered medication is for the duration that they're being restored to competency, and the minute they're restored, whether that's in our facility or they're transferred back, their medication order is no longer valid. So they have to continue to take it voluntarily.
Thank you. I think another easy one, does WellPath do the mental health screening at booking, or does mental health staff?
So our WellPath provides our mental health care as well. And so that screening is done by the nurses at booking. And they do the receiving screening or the intake screening as well.
Thank you.
And that screening is actually designed to be done by non-mental health staff. It's designed to be done by custody or anyone.
Thank you, Teresa. Could you speak again to the diversity in your jail system? Someone missed the makeup of the diversity in the jail.
Do you want to go back to that slide? I think it's near the beginning. It's like a pie chart. So essentially the summary is that looking at our county doesn't have a large population of people of color in general. And so I think further up, yeah, there you go. But what we see in our jail is about double the rate of people who identify as Black, and then a larger percentage of people who are Hispanic compared to our county's population.
Thank you. And regarding the competence evaluation, does the behavioral health psychiatrist do the evaluation, or does the court contract with an independent psychiatrist?
They contract with an independent psychiatrist.
Thank you. Those are all the questions I'm seeing in the chat right now. I'll check back in just a second and see if we haven't answered anything else. And I will put the contact information back up on the slide for just a moment.
Hey, Teresa, I saw that there was a follow-up on whether or not you take people with co-occurring disorders in mental health diversion, and I thought you might want to clarify that. So although we don't take people with who have no mental illness and substance use only, we do take people with co-occurring, correct?
Yes, we do co-occurring. The kind of fine line is if the severity of the substance use is so high that they need residential, we don't take them until that part has gone through. We don't have the ability to treat that severe of a substance use disorder.
Teresa, is that judgment based on any kind of assessment?
Yes, all of our staff are trained in ASAM, and they are able to do that level of screening. We refer people, our court screeners that I spoke of earlier, they are trained in both mental health and substance use disorders and know what programs those people would be eligible for, what level of care they'd be eligible for. So we are looking at all of it, and we do a lot of co-occurring. Our division does almost all co-occurring disorders.
Thank you for clarifying that. A couple of more questions. Can you tell us more about starting court-ordered medications earlier? How long does this typically take, and what obstacles did you encounter?
So the way that the court-ordered medications are written and the way that our council had interpreted those orders was that unless we were providing competency restoration, we couldn't use the court-ordered medication. So that had been our practice for years. And then when we started having conversations with Department of State hospitals around diversion, the issue of trying to start people's medications before, they were diverted came up, because we were trying to get people more stable so that they could be good candidates for diversion. And so what happened is we got our judges and our county council on the phone with Department of State hospitals and their legal team. We had a great conversation about what the law says and what we're able to do. So based on that, our council changed their opinion and said that as long as the people are receiving mental health treatment, they can receive the court-ordered medication. And I would say the biggest barrier is that there needs to be a lot of planning and staff available to actually administer medication. So 9 times out of 10, if there's a court-ordered medication, the person sort of knows that they have to take the medication either way, and so they end up taking it voluntarily. But sometimes people refuse, and in that case, it becomes a situation where you're having to force the medication on the person. And so you're taking a calm person and then you're creating a situation that can be very dangerous because you're trying to inject them with a medication. There's needles, so that's a big deal for us. We plan the day. It's not something that we'll do with just haphazardly. So if someone refuses their medications, we give them many chances to voluntarily take it. And then it's really our sergeant that's in charge of the behavioral health unit who plans the day, gets the staff ready, and makes the whole plan for it. So it's a really big deal if we actually get to that point.
Thank you. Do you have a constant observation unit? And if so, how did COVID affect it?
I'm not familiar with that term. I'm assuming that means like people that are being watched one-on-one by custody. Is that what that means?
Yes, I believe so.
Yeah, we do have people that are being watched either, visually or on camera at all times, especially obviously people that are high risk for medical or mental health conditions. And we do have one part of our jail where we have people on camera. It's in the newer part of our jail, but it also happens to be a good place to put people who have COVID because each cell has its own individual ventilation system venting to the outside. They're not negative pressure. We have 2 of those, but then when we run out of those, this area with video monitoring is a good next spot to put people. And it's been a huge challenge. I mean, housing people in general in a jail is like a big game of chess, trying to figure out who can get along with who and where they should be. And then COVID just shook that whole process up. And so you had people who were quarantined and isolated in different points in their disease. And it was all the classification team, really, they were just awesome. And it was a lot of work.
Thank you. Switching gears a little bit, is naloxone provided upon discharge for those with substance use disorder?
Yes, we have a couple of different ways we do that. So we offer it to actually anyone that's leaving the jail, we offer naloxone. But then we also, our substance use counselor also, the people that she's seeing for opioid use disorder, she also gives them a naloxone kit and talks to them about naloxone. And we have training available on our video, like our kiosks we have in the housing unit, which are relatively new. We had an awesome program before the pandemic that had been going for a couple of years with our syringe exchange program, but all outside programming stopped during the pandemic, so we really had to regroup.
Great, thank you. Does your diversion program cover both Penal Code 1001.36 or mental health diversion and DSH diversion?
It covers the first one.
The mental health diversion. I had to look that up.
Yeah. It's mental health diversion. Our program is the mental health diversion.
again, those are all the questions we have at the moment. We do have another question around the presentation after the event. And Sam, I believe that slides will be available through the Gaines listserv. Is that correct?
Yes, that's correct.
Perfect. Thank you. So we also let you know that there is a webinar attendance certificate. If you're interested in downloading that for personal use, you can do that now. You should have seen a file transfer box pop up on your screen. Under the file name, click the files you would like to download. It should turn blue, and then the download button should turn a darker gray. When you click the download button, it should initiate the process to download the certificate directly to your computer. If you have any difficulty obtaining the certificate of attendance for your personal use, please email Sam Rogers at srogers@prainc.com. That's srogers@prainc.com, Pra-Inc. Here is information on the next webinars hosted by SAMHSA's Gaines Center on May 18th from 2:30 to 4 p.m. Eastern Time. There is part 2 of the webinar series, Linking Healthcare, Public Safety, and Behavioral Health, Aligning Regional Responses with Identified Needs and Resources. On May 20th from 2 to 4 p.m. Eastern Time, there is the Early Diversion Virtual Learning Community on integrating forensic assertive community treatment, or FACT, teams into early diversion response. And on May 26th from 2:30 to 4 p.m. Eastern Time, there is a webinar on adopting a trauma-informed approach in drug treatment courts, resources for judges, court staff, and providers. Registration information for those webinars will be shared via the Gaines listserv, so please keep your eye out for that information, and we hope you can join us. If you haven't signed up for the Gaines listserv, then I encourage you to sign up. Here's a link. Just enter that link into your favorite web browser, and it will take you to a place to enter your contact information, and you can stay up to date with all of the Gaines Center's activities. Thank you again for your participation in today's events, and thank you to our presenters. If you have any other questions or comments, the Gaines Center's direct contact is here on this website, or you can go to samhsa.gov/Gaines Center, or here's a phone number to contact us directly. Have a good afternoon, everyone. Thank you.